So we'll talk about recent advances in coronary series. Like how before the PPT gets done. Show of hands, how many of you routinely prescribe coronary series? Very good. So only 1% of the audience is regularly prescribing coronary series. And what about the rest? Is there any reasons why you are not towards coronary series? I know all of us are, many of you will be cardiologists, so you prefer invasive angiography. I agree. I'm an interventional radiologist. I don't go through peripheral angios for my below knee angioplasty. Before starting it, let me give my disclaimer. I've been doing peripheral plasties for the last 15 years from 2011. So any artery which is less than 3 mm, my diagnostic rule is I can't measure the artery properly. So I don't trust my peripheral angiogram images, even if it is I who has reported that particular image. So I can totally understand if you're not into coronary CT, but the entire aspect of it, PPT is not actually. So the entire aspect of coronary CT is any vessel which is going to be less than 2 mm or 3 mm. It's going to be difficult for a scanner to pick up what exactly is happening in the artery. That holds true for anterior arteries, posterior arteries. It also holds true for coronary arteries. So the recent advances are towards identifying how these coronary arteries can be identified. It's a 20-minute talk, so I thought let's talk about 10 important recent advances. Again, these are not recent advances in the sense of this is being going to come into vogue in the next 5 years, 10 years. So it's not like that. This is something which is being practiced day in and day out in any particular center which has a cardiac CT. Except for maybe the photon counting CT. Photon counting CT, there is only one center in India which is doing it. Reliance Center. It is in Mumbai. The cost of the machine is going to be 25 crores. Because of that, that is the only particular reason advances which will not be available for many of you guys. Remaining 9 things which has been listed in this particular slide is something that you can ask for to your radiologist, and that is something which is available at your footsteps. So before going into all this mind-boggling terms of what is photon counting CT, fraction flow reserve CT in CT. Madam was talking about how we calculate FFR in angiograms. I'm going to talk about how FFR CT is going to be done in a CT machine. What is standard score? What is high risk plaque imaging? And cardiovascular biomarkers. The age-old decades ago, we have been always calculating calcium score. You calculate the calcium score, you'll be able to tell whether the patient is going to need a statin therapy or aspirin therapy. Now we have better cardiovascular biomarkers such as perivascular fat inflammation, epicardial adipose tissue, few obesity markers also in imaging which will be seen. Apart from that, we have extracellular volume imaging and a plaque reduction in this direction. Let's go through each and everything. First thing is photon counting CT. So the conventional CT, if you see in the conventional CT, why the resolution was very poor is here we are able to see that X-ray is going to get converted into light, and after that it is going for interpretation of images. Whereas in photon counting CT, what happens is the X-ray is directly converted to an electric signal. So that particular step is outdated right now. Because of that, the resolution is better. How good is the better? Let's see. This is canine models in which they have shown. Let's go to the human model itself. This is how a normal coronary CT is done. This is why many of us do not trust our CT images, because we get such a blurred image in which this is a calcium and this is a normal lumen of the coronary artery. Now to calculate the stenosis in this particular segment is going to be very difficult for us. But when we have photon counting CT, here we are able to see that the calcium plaque is very clear. And the lumen is also very clear. So here we are able to see nearly 50% of the lesion is having, there is a 50% stenosis. So because of this, the coronary CT is becoming more interpretable and easy for us. To summarize about photon counting CT, what we need to take home is the resolution has come down to 0.2 mm. When I started, I told anything more than 1 or 2 mm, the CT is not just coronary CT, any other part of the artery is not going to be very clearly defined. This is one thing in which they promised that it's going to be 0.2 mm, and we saw the proof of the same. Heavily calcified arteries, thumb rule. If the calcium score is more than 400, don't go for a coronary CT. That is a thumb rule. In my department, I say calculate the calcium score. That gets done within a minute. And if it is 0, well and good, stop the study until you are suspecting a soft tissue plaque. And if it is more than 400, again abandon the study, because in the heavily calcified arteries, it becomes very difficult for us to make a sensible decision. Post-net evaluation and compressed CAD. So these are the things in which we will be able to see in the case of a photon counting CT. The only center which is having right now in India is going to be Mumbai. The second thing is going to be fraction flow reserve CT. So the question is, do we really need an FFR in low risk patients, low risk anatomical stenosis? You don't need, because it's going to be less than 30%. Higher stenosis group, completely occluded, that is really not a point of efficacy. The only groups in which we need is intermediate risk anatomy, which is between the low risk and high risk. So in this, we have an algorithm in which CT, madam told different numbers, but we have a thumb rule of 0.8 and 0.something. If it is more than 0.8, then we assume that the intermediate stenosis is not going to cause any functional narrowing in that particular artery. That is, the blood flows is going to be good distant. Let's see it with a couple of examples. For example, there is a stenosis here. Now the million-dollar question is, do I stent it or is it a significant stenosis? So when we do a CT, already we have these kinds of images which is circulating around. Now when we upload this particular images into a software, we will be able to tell distal to this particular stenosis what is the amount of blood which is going. So if it is more than 0.85, it doesn't matter. But if it is less than 0.75, it means that is not just a stenosis, it is causing a reduction in blood flow distal to the stenosis. So it is not just stenosis mapping, it is also about the blood flow which is going through it. So there are three stenosis which we are able to see, three calcified plaques. The question again, what is actually happening to the blood flow which is distal, which can be calculated even in a CT, which is a non-invasive way in which we do the fractional flow reserve which is going to the distal part of the blood. So this is a summary of it. Remember these values 0.8 and 0.75. And yeah, the only thing that I need you to understand is it's not just an array, it also concerns about the exact blood flow through that particular artery. How is it done? For most of you who are refusing to believe that the FFR CT can be done, there are four important parameters we take. One thing is the angle of insertion, the angle in which the blood flow is going through that particular stenosis, which is called the alpha angle, the luminal diameter, the distance of the entire hill area. All these things are put in a computational flow diametrics model to tell us whether that particular blood flow is going to be correct or not. So, what is the accuracy when compared to an invasive FFR? It is going to be more than 80%. There are various articles, you can go through this particular article for further references. And the measurement is supposed to be 2 cm distant to the stenosis to identify the exact amount of FFR CT which is happening at that LU. So, it's a non-invasive way. Coming to the third recent advances, cataracts and coronary CT. So again, another thing is whenever you're getting a CT report, when I talk to my cardiologists, they always keep saying, John, 50% put the angle, 70% put the 80% put the angle, 100% put. Always try to understand when we are reporting, we report in two particular ways. Most of us are tend to report in this particular thing, that is diameter. If the diameter is 50%, the cross-section area is going to be even further lower down, it's going to be 75%. So most of the radiologists, including me, we try to report the stenosis in case of diameters rather than cross-sectional area. If you specifically ask for cross-sectional area, yes, it can be done. Here we are able to see the same thing can be shown in a cross-sectional area. But try to understand why we do not do it in the cross-sectional areas, because here the entire length is seen. So because of that, most of your coronary CT reports will be having a diameter area reduction rather than a cross-sectional area reduction. So when you interpret it in a higher degree. So that both of us are looking at the same numbers. So a single-page summary of what we spoke about cataracts is, 0, 1. Now we have started giving numbers like everything in imaging is going to be adjective. You talk about malignancy, you talk about breast, you talk about prostate, you talk about anything, you are going to give numbers. So anything which is less than cataracts 2 is going to be benign for the patient. 5 is going to be total occlusion. 4 is going to be intermediate. Coming to the fourth important reason, which is high risk plaque. The question is not about whether there is a plaque. The question is about whether the plaque is going to rupture. Whether this can be computed in CT. For example, normally when you see a CT report, this is what we report. We report whether it is a fatty plaque, soft tissue plaque, whether there is calcium. Heavily calcified, we call it as a calcified plaque. If there is no calcium, we call it a not calcified plaque. And if it's having areas of calcium, we call it as a mixed plaque. So, we have started going from just a plaque imaging to high risk plaque imaging. Before saying what is high risk plaque imaging, let me show you this particular slide. There are 4 important features in CT, which is posterior remodeling, a lipid core, a napkin film sign, and spot calcification. For example, in the conventional imaging, if you see 2 specks of calcium in a coronary artery, we will report it as less than 10%. But according to high risk plaque imaging, if we see these 2 calcium specks, it means that this patient is having a dystrophic calcification, which is leading to an inflammation which is happening in the heart. So according to high-res plaque imaging, even 2 specks of calcium which is seen in the calcified plaque can rupture later. So how does these images look? Just for you to see. So this is how your posterior remodeling will look. It will be just a slight bulge outside the artery. Low attenuation plaque, if you see it is more blackish, lipid is going to be more black. So you see a more black plaque, it is going to be a lipid-rich plaque. You see such small, tiny specks, it's a spotty calcium. You see a napkin rim sign where you see a cross-section area which is more than 50% involved. Then if you see any of these 4 kinds of plaque in your CT report, then it is going to be a high-risk plaque. Even if the stenosis is going to be less than 50%, these are the plaques which are going to rupture. This is a better image to show the posterior remodeling. You can see this particular wall is straightforward. On the contrary, the other wall is going to show an elevation, which is because of the posterior remodeling. The cutoff is going to be 1.5. So let's move to the 5th one. Yeah, calcium score is something that all of us are clear about. So just to summarize about calcium score before going to the other recent biomarkers. Calcium score more than 400 is going to be severe, 0 is going to be no calcium, and between 1 to 99 is mild, and 100 to 400 is going to be moderate. The limitations of calcium score are more important. For example, if the plaque is going to have calcium, you are going to pick it up. If it is going to be a soft tissue plaque, you are not going to pick it up. You are going to ask if this patient is having a calcium score of 0, is not going to have any ischemic risk disease, but this patient might have a soft tissue plaque. Second thing is it cannot assess severity, and some of these patients, last month I opened up 3 MCAs, all of them were within the age of 30 to 35. None of them had calcified plaques, at least in the brain. So the same thing holds true for even coronaries. So recently we are seeing more and more of lipid-rich plaques, ICANS in our population. So calcium score of 0 doesn't give us a reassurance that the patient is going to be quite safe. How is it calculated? So this is minimal, moderate, and severe. It is extensively calcified. We have an objective criteria. Once it is calcified, we put the HU. If it is more than 130 HU, we take that particular thing, and then we multiply it by the square meter. I'll just give you an example of how it's done. For example, here the calcium plaques area is 50 millimeters square. We can calculate it in C. The attenuation, which is going to be 450, we are going to multiply both of it, and the value which we give 60, which is a product of the attenuation HU, and the area is going to be the final calcium score. I'm not going to how calcium score is going to help in statin and aspirin therapy. You're well versed with it. But what is the reason advances in calcium scoring? So from calcium scoring, again we have started moving to recent biovascular markers. So what are the recent cardiovascular markers we have? One is perivascular fat attenuation index, epicardial adipose tissue, high-risk plaque imaging, which was already talked about, and myocardial CT markers. Let's see what these things are. What is perivascular fat inflammation? So basically, there is a coronary artery. Right now, we are more worried about what is happening to the coronary artery, what is happening in the lumen, what is happening in the wall. Perivascular fat inflammation is going to talk about what is going to happen in the fat which is surrounding the coronary artery. If there is an inflammation, that means that the artery is under stress. So how are we able to see it in CT? The attenuation value is going to move towards minus 30. So we have 2 cutoffs. If the attenuation value of the fat is more, minus 30, it means the fat which is around the coronary artery is an inflamed fat. So even if the coronary artery looks normal, it is a artery which is having inflammation going on within it. So what is the reason for it? I don't want to bore you with it. Lots of leptins and all those theories comes into play. Let's see how we calculate in CT. So for example, this is the RC, this is the LAD. So this entire green area is the area, and we are going to stretch it out, and we are going to give the score from minus 190 to minus 30. More towards minus 30, it is going to be an inflamed fat. So this is a CT image. Here you are able to see the more yellow thing means it's a benign thing. The more brownish, it is going to be an inflamed fat. So this particular thing can be done in CT right now. Again, another image in which all the 3 arteries, RC, LAD, LCX, wherever it is red, it means that the fat around the coronary is inflamed. That is fat attenuation index. This is a summary, just one take home point. This is a summary slide of it. Minus 30 means an inflamed fat, minus 190 is a normal fat. Coming to the 7th reason advances, it is epicardial adipose tissue. So let me clarify a few terminologies. What is pericardial fat, paracardial fat, epicardial fat, perivascular adipose tissue, non-perivascular adipose tissue. These are basically adipose tissues which are around the heart. So this was basically for radiologists. So bear with me when I am trying to differentiate between the pericardial fat and paracardial fat. In CT, what we are able to see is a pericardium. This white line you are able to see, right? This is a pericardium. Any fat which is going to be within it is going to be called the epicardial fat. The fat which is going to be outside it is going to be called the paracardial fat. What we are seeing in purple here is the paracardial fat. What we are going to see within the pericardium, green is the epicardial fat. Now, what is pericardial fat? Again, the same thing is shown in MRI. Here we are able to see the pericardium very beautifully. This black line which we are able to see, right? That is a pericardium. In MRI, we will be able to see it even much more clearly. So, the fat which is within it is the epicardial fat. Fat outside is going to be paracardial fat. The sum of these two fats are going to be called the pericardial fat in image. So, what's the importance of it? We are least bothered about pericardial fat. How a fat deposition is there in the pericardial area, it doesn't matter to the person at all. But if the epicardial fat is increased, it directly is going to reflect on the obesity and biomarkers and metabolism of that particular person. Let's see how it is. So I think the same epicardial adipose tissue can be calculated in echo also. This is how we do it in CT. Again, the pericardium and this particular area which is dotted in yellow, and this is MRI. So this is important. So epicardial fat tissue and pericardial fat tissue, the important differentiating feature is this is a storage fat, whereas this is directly going to contribute to the metabolism and inflammation. Coming to other obesity markers, we already saw two obesity markers. One is the epicardial fat attenuation, other one was perivascular fat and epicardial adipose tissue and perivascular fat inflammation. What are the other fats? And we know that visceral fat is more important to contributing to sudden cardiac death rather than subcutaneous fat. So at the level of L3 vertebra, what we do is we calculate the amount of fat which is seen in the subcutaneous vein and the fat which is seen within the viscera. What are yellow shown here is the visceral fat. What are red which is shown here is the visceral fat and yellow is shown here the subcutaneous fat. However obese that patient is, if it is only the subcutaneous fat, it is not going to directly correlate with your cardiovascular events. But even if the patient is thin and the visceral fat is higher, it means that the patient is going to have a acute coronary disease and metabolic disturbances. So there are three types of adipose tissue. So what we already saw was subcutaneous fat and this visceral fat. These are the easy things. In any imager, you put it at L3 vertebral level. L3 is the point at which the patient is too stout. Take one section that's more than sufficient. The radiation dose is going to be less than an X-ray. You can calculate the entire visceral fat within a matter of minutes. Now recently, intermuscular adipose tissue fat. Like I was talking to sir also, like there is an entity called sarcopenia or muscle wasting which is occurring in the bodies. So when that occurs, what happens is, this is the muscles. So between the muscle plane, what all fat is going to get enlarged because of this atrophy is going to be reflected and picked up by the intermuscular adipose tissue that can also be calculated. Again, the objective criteria for this is going to be more than 150 centimeter square and this is going to be more than 20 centimeter square. So from qualitative to quantitative data is also there as far as adipose tissue. Coming to fat quantification, we do MFCs, right, for grade 1 fatty liver, grade 2, grade 3 fatty livers. Gone are the days. Right now what we do is MRI quantification of liver because here we are able to tell the exact percentage. There is a software which is needed for it, it's on software and there is no radiation involved. So here, this is a patient whom I did a couple of days back. This patient came from Trichy. This was a liver transplant donor. We wanted to know what was the exact fat deposition in this liver. For example, if had we not had this Dixon software or MR quantification, what we would have done, we would have just done a liver biopsy. We would have sent to the pathologist to ask for how much exactly is the fat. Now, since we have this MRI quantification, what we do is we just take the particular sequence, put a range of interest. It tells us very clearly that it is 7.5%. So the exact value till the percentage of fat can be delineated with just a simple sequence. This gets done within 2 minutes. There is no radiation which is important. Coming to the ninth recent advance, which is extracellular volume. So extracellular volume, like I saw a couple of speakers talking about late volume enhancement and cardiac MRI, and so ECV is one thing which is going to actually contribute to your interstitial fibrosis, scar tissue, and all those things put here. So if your late gadolinium enhancement is going to pick up the scar, very simple. When they ask me a cardiac MRI, there's only one inch they tell me. John, tell me whether we can revascularize this patient or not. Already the scar tissue is there. If I open it, will it be of use to a patient? Simple sequence. One sequence, put the T1, late gadolinium enhanced delayed imaging. What was white is already gone. Then there is no point in revascularizing that tissue. Whatever is remaining is the thing which can be picked up. So that is one of the components of ECU. Other things are going to be any diffuse infiltrated disorders. Let's see what exactly it is, how we calculate it. It can be done with the CT and it can be done with the MRI. It is the same formula. 1 minus hematocrit multiplied by the difference in myocardium, and the hematocrit should be taken on the day in which you are doing the CT or MRI. How do you do it? Take a non-contrast CT, then after 15 minutes take a contrast CT, add the differences between, put a marker in the myocardium and put in the lumen between the first image and the 15-minute image. You have the formula and voila, ECD is done. Same in MRI. MRI, we actually go for a cardiac viability. As part of cardiac viability, we will be doing an ECD thing where the scar tissue is more important. So remember these important things. Hematocrit should be calculated on the same day, and CT and MRI should be done at an interval of 10 minutes and 15 minutes. This is a single page summary of it. What I like you to remember is the important indications: cardiomyopathies and dilated HOCMs, infiltrated disorders, amyloidosis, and myocarditis. So that brings us to the end of cardiovascular risk information. My last slide is going to be A and plaque and risk reduction. So A is going to just calculate all the remaining 9 recent advances, put it in a particular score. It is going to take all those things: fat attenuation index, high risk plaque formation, your calcium score, and integrates the above marker into a single particular thing. How it does? It delineates all the coronaries which is given to it. It tries to identify which is the normal coronary, which is the one which has stent, which has myocardial bridging, which is the movement artifact, and based on it, it is going to give you an answer. So this is how it takes EAT, ECAT, all the 4 high-risk plaque formation which we saw, and the stenosis whether it is going to be a significant or not without using invasive angioplasty. Thank you. My sincere thanks to Calwin Hospital and Dr. Calwin sir for giving me this opportunity. This particular talk will be available in YouTube as well as in Insta. So if any of you have any questions, then just go through it and you can ask me any questions right now.
Thank you, sir. We learned many points regarding the recent advances in the coronary series. Any questions from the audience?
How long does it take for the FRCT to come?
So FRCT is already works. FRCT.
You have said it's a software based.
Yeah, it is a software basis.
How long will it take after the CT?
So there are 2 ways in which we do it. Actually, the CT can be done in any department which is doing. The one part is the computational cloud. There are 2 ways in which it is done. One is a cloud software and another is a non-cloud software. The cloud software is going to take a couple of weeks because it's a US based software. We said it, and the cost is also proportionately higher. It is going to be around 60,000 to 70,000. The other one, which is not cloud software, is case per case CT. That is around 10,000. That takes up 3 to 4 weeks.
And what exactly is napkin? What do you say that?
Napkin terms, I can go through. So basically, it is the lumen volume and the napkin ring. We have a central lumen and there's a peripheral ring. The peripheral thing is a calcium, and the central part is the necrotic component. So if you have a plaque which is looking like that, that means that is a high risk plaque.
What is the real problem for a cardiologist, for an interventional cardiologist, to do procedure on this coronary CT alone?
So I don't understand the question. What is the problem?
The first question.
Yes, sir.
Many are not doing coronary.
Exactly. I understand.
The reason is when a cardiologist does the diagnostic and therapy.
True.
It becomes only almost diagnostic.
So only one thing, sir. It is a negative predictive value. When someone asks for a coronary CT, we do a primary level of screening of all the forms which comes to us. For example, if the patient is having a clear-cut MI, there are many patients who are coming, they feel very scared of going to a cath lab. One of my professors came to me, he was having clear-cut signs of MI. Really no point doing a coronary CT. When you know the answer is going to be positive, there is no point spending your time in a coronary CT getting. So what exactly is the role? It has a negative predictive value. What does it mean? For example, I'm pretty sure this patient is going to have nothing in invasive angiogram. I think of coronary
non-obstructive lesions can be detected.
So non-obstructive, as ma'am has pointed out, actually non-obstructive lesions can be picked up, sir. Actually, but again, such entities it's very difficult. For example, we just learned about the entity called that there is a non-obstructive coronary things. So those things will again turn out to be normal. If a patient is having dyspepsia-related chest pain, and you want to be safe before sending the patient out of your OP, then you can ask for a coronary CT. So that is one thing. Second thing is you want a baseline biomarker. For example, you want to know what is the calcium score. There you can do it. My control is if the calcium score is more than 400, I don't report. My colleagues do. Even if it's more than 400, they do the reporting. I say when it is more than 400, I won't be able to give any sensible report. So I'll stop it at calcium score. I'm not going to do a coronary CT evaluation. It has a high negative predictive value. If it is normal, most likely your coronaries are going to be normal. No need to get a invasive coronary angiogram. If it's positive, you are going to send it to a cardiologist. Yes, sir.
The most important indication for a coronary CT is for a post-CABG patient.
Yes, sir.
And the calcium score is immaterial in the post-CABG patient. And that is one of the first indication. And any patient who has undergone a CABG aspirations post 5 years has to have a CT coronary angiogram.
The reason why it is actually because again anything which is in our field we never have to do other ones. Why this post-CABG patient alone comes for coronary CTs? That is because many of these patients will have an occluded graft. Now, when I'm cannulating artery, for example, I keep on poking a renal artery and keep on poking an ATA, I'm not very sure whether it's there and I'm not able to cannulate it or it's totally occluded. So, in a patient who's having a graft status, there is a high chance that these grafts will be occluded. So, in such patients, when you're directly taking the patient for an invasive coronary angiogram, there is a high likely chance that you may perfect. So, in all post-CABG status, you're not able to move the coronary arteries. And before you label that it is occluded, it is wise to get a coronary CT. Where you can see the lima, you can see the venous artery. I agree with this.
Thank you, sir. Thank you for the enlightening session.